All right. So again, this class is geared not to make you guys CCEMTs, Ps, whatever. It's not to make you a critical care nurse or an RN or anything else like that. Obviously, you will not be able to go work in an ICU right after this lecture. However, what I'd like to do is kind of give you some, throughout the day, some of that basis foundation, just so that you can say, hey, I've heard that before, right? Because I said a whole bunch of acronyms and words a little bit ago that you guys probably never heard of and have no idea why we use it or what it does. So obviously our goals for this component that I'm going to be talking about is we don't want your heart rate to be faster than your patient's. So hey, I'm going to be talking a little bit about vasoactive drips, and sometimes it's just just enough just to say, hey, take a deep breath, you're going to be fine. Also want to make sure that you don't sound like a complete moron when you come over there to take a handoff from the nurse and you're like, I'm going to transport this patient, but what the heck is all of that stuff? So hopefully you'll at least know a little bit more about that. I mean, does that look intimidating to anybody? Yeah, can you imagine that? I've actually seen something like that. I've actually taken care of patients with something like that. So obviously this class is not, like I said, not going to make you a critical care nurse. It's not going to make you, huh? What's that?
Sick or not sick.
Yeah. Well, where's the patient? No, yeah, sick or not sick. So, vasoactive drips. What are they? Anybody know? What's a vasoactive drip? What do I mean when I say vasoactive drips? Okay. So it must have to be, if it's a drip, it's some type of infusion, right? That's required to maintain, like you were saying, pretty close, hemodynamic stability. All right. So your patient, and in this case, we're talking about critical care transport. What that means is, hey, I'm going to go show up at one hospital, do an interfacility transport to a higher level service, right? Say to a community hospital ED that has a patient that needs to come up for ECMO when they can't do ECMO, okay? And they're going to be on all kinds of drips, and you're going to be like, I don't know how to do this. What am I doing? All right. So that's the kind of thing that that you might see some of these meds, even if you've never ever touched them. So it's important to kind of understand some of the basis and some of the foundations of these meds. As far as the importance of knowing when these go is not, I mean, obviously if they're already on it when you take over their care, it's not a really big deal, but just some understanding why they probably went on it. If they have a MAP of less than 60, that's concerning. What's a MAP, guys? Do you absolutely. Do you know how to find it? How to calculate it? What's that? Plus. It's a plus. Okay, so your systolic plus 2 times your diastolic. Write it down. Your systolic plus 2 times your diastolic divided by 3. Divide the whole number by 3. So that will give you your MAP. All right. That is a very important number to sometimes know, because in the ICU, a lot of times those patients will be titrated or managed based upon the MAP, that patient's MAP. So the doctor will actually say, maintain a MAP of 70. Okay, titrate to effect. Well, what is effect? We want to know. Is there a benefit to having this mess here of all these different vasoactive agents? Could I just have one? Or why would somebody need all those? Maybe this is a little overkill, I agree. But sure, certainly, there are times when having multiple drips running is appropriate, even if we're trying to achieve the same objective, okay? Let's say the objective is to cause vasoconstriction. I think you brought that up earlier. Okay, if the objective is let's cause vasoconstriction, having combined doses of different types of inotropes and vasopressors might actually be beneficial, because what happens is we tend to blow out these receptors with really high doses. Or if a person's body has actually been on this type of pressor or vasoactive drip in the past, they will be less responsive to it the next time, okay? So it actually is beneficial sometimes that you don't give them max doses, but you actually give them synergistic medications that have combined outcomes with the same effect. Does that make sense? So a little bit of pharmacology 101. How many of you have heard of an adrenergic receptor site? Have we just covered it? Yeah. All right. So on your whiteboards, I would like you to list off as many adrenergic receptor sites as you can. Or not sites, but adrenergic receptors. What are they? All right. Whiteboard's up. Tell me what you got. Good. All right. So, Mr. Colley, what do you got there?
Alpha 1 and 2, beta 1 and 2, dopaminergic.
So, all right. So these are common adrenergic receptor sites found in many cells throughout the body. When they're activated, what is it that happens physiologically to the person? Absolutely. So the sympathetic nervous system starts firing off, right? Okay. What is it that binds to these different sites? What are they? Hint. It's on the board. Huh? Speak up. Don't be afraid. Catecholamines. All right? The catecholamine actually will bind to these receptors. And what happens when the catecholamine binds to the receptor? Flips the switch on. Okay? So it turns it on. It makes whatever that receptor is supposed to do, makes it start working. Okay? So most common catecholamines that we'll see, and our body makes them inside itself, is dopamine, norepinephrine, epinephrine. You've heard of these things? Epinephrine sometimes referred to as adrenaline. The dopamine I put up there on the top because actually dopamine is kind of interesting because it'll actually at various levels work on various different receptor sites depending on how much is given or how much the body creates, and it can actually turn on some of these other. Give me 1 second. Sorry, guys. I don't know why it's doing that. All right. So it actually turns on some of these receptor sites, even if it's, at different areas, okay, of the body. So here are those, what Mr. Colley was talking about, these different receptor types. We have the alpha 1, alpha 2, your beta 1, beta 2, and your dopaminergic. Where are they found? So that's important to know. As far as what they're going to end up doing for us. So our alphas, where are alpha 1s typically found? Huh? No, that would be your betas. Where would the alphas be? It's good. Alpha receptors are primarily found where? Huh? In the periphery, okay, in your vasculature, okay? So in your arterioles. When they're activated, what does it do? Okay, it causes constriction. How about your betas? Okay, is there beta in the vascular system? Yeah, there are beta receptor sites there as well. Where are they mostly found? The heart. Okay, so it actually has a strong effect in the heart. However, what does beta do that alpha doesn't do in the vasculature, out in the blood vessels, in the arterioles? Here's a tool. Alpha receptors, you just got to remember our ABCDs. Alpha receptors cause constriction, whereas beta receptors cause dilation when it comes to out in the vasculature. Oh my goodness, I see a bunch of blank stares. So that must mean, but I thought if beta is agonized, it causes constriction. No, it actually does not. It's actually because there's more alpha receptors found in the vasculature than beta receptors. Usually the alpha takes over, and I'll explain that here in a second, okay, when we talk about epinephrine. One other way to remember it too is as far as beta receptors. Beta 1 is typically found where? The heart, whereas beta 2 is? Okay, so you have one heart and how many lungs? 2 lungs. So that's one way I remember it as well. Now we need to switch gears just a little bit because I'm trying to drag you all along with me. We're doing some review as far as pharmacology goes. What is an agonist? If I'm talking about a medication that is an agonist, what is it doing? Okay, activates what? Okay, it activates the reaction, and in this case, it activates that receptor site. What about an antagonist? What's that going to do? It's going to block the receptor site. All right, so this guy here, if we got an agonist here, and if he eats my little man here running, he's trying to get away, he's going to be full. He'll have a little more energy. He'll be able to get what he wants. He'll be able to do it. The poor guy here, he's feeling the fight or fight response right now, I'm sure. So just remember, an agonist creates the same physiological response. Okay, the physiological response that we're looking for as far as in the receptor sites, what that receptor site is supposed to do. On the flip, we have an antagonist. And I put a piece of wood in this poor shark's mouth because he can no longer bite down, right? So we are not necessarily getting rid of that receptor site. We're not necessarily saying that all of them are going to be filled up and none of them are going to work. However, we're blocking enough of them that we're not getting that effect that we're looking for, okay? Can anybody tell me a medication that does this? I can't hear, I apologize. Atropine in what way? Okay. How about another one? That's good. Huh? Atrovent. How does Atrovent work? Atrovent's more of a steroid, I think. That's why I'm not. As far as a blocker, help me out. Follow. Is that Atrovent's a steroid only, isn't it? Steroid. Okay. I don't want to confuse people, but that's fine. How about let's go with the biggest tried and true that'll help everybody understand. If grandma gets in a car accident, she's out laying on the road, okay, but her heart rate's tacking at it at 65. Anybody think the reason why she might, she's bleeding, she's lost a lot of blood, it's hot outside, but she has a heart rate about 65. She might be on beta blockers, right? Because it's blocking that action. So you can certainly consider that. It doesn't mean that's the only thing. But that's what I'm trying to talk about, is that, we have things like beta blockers, we have that actually block that sympathetic nervous system response that we would normally expect to see. All right. Talk about cardiac output a little bit. So how much blood do you guys have running through your body at any one time, approximately? Huh? All right, put it on your board since you don't want to say it. How much blood do you guys have running through your body at one time? Approximately. Give me some approximate numbers. Thank you. It's because we're a little bit bigger guys, right? Yeah. Absolutely. All right, so roughly 5 liters, right? 4 to 6 liters. You know that your heart has to pump all of that blood every minute. Every minute. When you think about the amount of work your heart does, it's pretty amazing. So how do we find out what our cardiac output? What is our cardiac output? It's what's that? Yeah. So it's our heart rate times our stroke volume. How much we're able to eject with each stroke of the heart, right? With each contraction of the heart. What are the components of the stroke volume? Do you guys remember that? What three things do we need to create stroke volume? I'm helping you out. You guys got a cardiology test coming up. Is any of this going to be on there, Paul? Absolutely. The components of the cardiac output are, and they are cumulative, okay? We need all three of them. What is it? Preload. All right, good. The volume of blood that's coming back to the heart. It doesn't do us any good to pump forward if we ain't got nothing to pump, right? So we have to keep that pump primed. This is the filling of that left ventricle during diastole. When does it fill up? When does our heart fill up? During diastole, okay? So we got to have preload, which is what? It's the amount of blood, it's the force of that blood coming back into the ventricles, okay? What else do we need? Someone other than Stuart. What's that? All right. We need some afterload. All right, what's afterload though? Okay, so resistance, I like that word. I like resistance or pressure. It's the amount of resistance that the heart has to overcome in order to get the blood back out of the heart. So if somebody who has hypertension for a long time, what do they have to do in order to get that blood out? They have to increase the force of the contraction, right? What happens to any muscle as it's being forced to work harder? Huh? Hypertrophy. Well, yeah, that's a nice big word, but in ultimate, it bulks up, right? When we work out, when we go to the gym, our muscles bulk up, right? The same thing's going to happen to the heart over time. And while I would like bulky biceps, I don't so much want a bulky left ventricle. Got me? So, because that causes another problem. And the last one is the contractility. All right? Contractility. So we need all these three parts in order to have what? The stroke volume. All right? We need all three parts. And contractility has three parts of its own. We call it chronotropy, inotropy, and dromotropy. And each one of those parts actually are very important in determining that contractility, okay, or that force at which it's going to contract. Chronotropy deals with the rate, whereas dromotropy is the conduction of the velocity. Inotropy is the contractility. But where does all this stuff happen in the heart? Where does it mean? What does it mean to us, right? Chronotropy. What is our pacemaker? What is our pacemaker? We should all say it out loud. Pacemaker is? A pacemaker is? Absolutely. And what does it have to overcome to get to the rest of the ventricles? Where? What? AV node. Absolutely. So, chronotropy is basically the determination of the rate, whereas it is created by the SA node. How often does the SA node fire in a healthy individual? 60 to 100 times, all right, in a healthy individual. How about the AV node? What if we have a complete first-degree heart block? We have what problem going on? That SA node is not firing, right? So, how fast does the AV node go? This is for bonus points.
46.
Sweet. How fast?
46.
Absolutely. All right, so we have to have a certain amount of velocity, okay, to get through that AV node and down into the, what fibers? Purkinje fibers, absolutely. And ultimately, we are looking for contractility, okay, in the ventricles, meaning a harder pump, and that would be entropy. All right. So if I say, what class of drug affects contractility, what would you say? An inotropic drug. Okay. What class of drug affects rate? A chronotrope. All right. So what class of drug would a beta blocker be? A chronotropic. Good. All right. So each beat has a specific stroke volume. All right. Stroke, stroke, stroke. You got me? What is the average stroke volume for a healthy individual? About 70 mLs, right? So each one of these, if they're functioning, if the ventricles and everything is functioning properly, should be ejecting about 70 mLs per stroke. When we talk about the resistance that's got to overcome, if you've got great big, large vessels, is it going to take a lot more pumping to get through that to get the same effect versus just a little bit? This is just a visual to hopefully drive it home. All right? We have all these drugs available to us. Any of these drugs look familiar? All right? We have norepinephrine, dopamine, phenylephrine, vasopressin, epinephrine, dobutamine. You see these before? The thing I want to point out here is that the norepinephrine, what is that? Do you guys know another name for that? Levophed. That's right. Levophed, its action is on what receptor? Huh? I didn't hear you. Okay, everybody? Thank you. Thank you. Come on in. Anyways, dopamine acts where? On what receptors does dopamine act? Right. And it's based upon what? Huh? That's right. Everybody hear what he said? It's based upon dosage. Okay. Phenylephrine, alpha. Okay. Everybody say it. Phenylephrine is alpha. Vasopressin is where? Okay. Epinephrine. Everything. Absolutely. Dobutamine. Very, very selective to beta 1, actually. And where is beta 1 primarily found? In the heart. Absolutely. So you guys got it? Is this making sense? Am I drawing a big picture in for you? All right. Why is epinephrine then? Does epinephrine cause increase in systemic vascular resistance? What does that mean, first of all, when I say that? Increased systemic vascular resistance. Vasoconstriction. Does epinephrine cause vasoconstriction? But it's a beta block, but it has beta agonist effect. Okay? Say it louder, Daniel. There's more alpha than beta. You look, okay? So the effect in epinephrine is not that it doesn't have the vasoconstrictive qualities of an alpha. It's just tempered by your beta. But there is still more alpha than beta. Hence the reason why, I think I had a laser pointer or something cool on this thing, but I do. Anyways, so if we're talking about Levophed, it's all alpha, just a little bit of beta. So what do I expect? If I'm looking at my meds here, which do I expect a much stronger vasoconstriction effect? Norepi versus what? Epi. I'm going to expect norepi to be much more, much stronger as far as vasoconstriction, right? Good. So that's kind of this is kind of what the route I want you to think, because I don't know which drug you guys are going to get on your national registry exam, but I do want you to understand some of the basic fundamentals of the adrenergic system. You got to. You got to. It's the basis for all cardiac meds. Okay. I'm not going to go over that. General points about titration. I just want to tell you, when you're taking over a patient, okay, they're giving you their patient to take care of for transport to the next hospital versus, and they've got all these drips. You're going to have to start asking some questions, probably because you never transported a patient with these meds, right? So some of the questions you're going to want to ask is, how much are you titrating by? What are you, every time you titrate, are you going up by 5, down by 5? How are you doing it? Okay, you need to find that out. What are you titrating to? What is your end goal measurement? Okay, is it an A line? We're going to talk about A lines later with Becky. Is it a blood pressure cuff, a regular cuff that goes on the arm? Are we titrating to MAP or to systolic blood pressure? What is it? You need to know these things, okay? When you're running a drip, dopamine, epinephrine, whatever, you got to know what parameters they're running them on, because you want to keep those same ones throughout your transport. There really isn't a hard and fast rule, okay, as far as how to do it. And another thing is, some people think that this is automatic, like you titrate, you either bump your medication up or you back it down a little bit, that you're going to have an instant effect. You're not. So you got to wait at least 5 minutes. At least 5 minutes to kind of find out, hey, am I getting the effect I'm looking for? Okay, so it's not magic. I mean, it may seem like magic, but it's certainly not going to happen as quickly as you think. Another thing is, I like this. Don't chase your tail. Do the easy things first. If your patient starts becoming shocky, how can you give them a 500 ml bolus immediately? How's that? Lift the legs up. Do we do Trendelenburg anymore? No, we don't put people in T-Berg position. It increases their ICP. However, what we can do is just lift their legs up, okay? So what are we doing by lifting their legs up? We're shunting that blood where? To the core, to the vital organs, to where we need it, all right? Epinephrine, I'm going to blow through a few meds, and then we're going to be done. I'm going to hand the time over to Hugh. Epinephrine, just remember, it's an agonist to all adrenergic receptors, okay? Pretty much, it loves them all. They're made for each other. However, epinephrine is really hard on what organ? Say it loud, guys. The heart, absolutely. So we want to be very cautious in our patients that we give this to. Very often we'll see these, the type of patient that we're going to see running an epi drip is going to be a pediatric patient. Why do you think that is? Their hearts are they're definitely more resilient. Their hearts are younger, they can handle it, okay? So we'll definitely see that. We might also see it in a patient who we just got ROSC on, if that is the drug that brought them back. I always say when I'm teaching ACLS, use the drug that worked, all right? So start the drip of the drug that brought them back. This look familiar to anybody? This is actually the algorithm that comes from the AHA for their stuff. But basically, they recommend 0.1 to 0.5 mics per kilo per minute for post-cardiac resuscitation care. That means that long-term drip. Or an adult with bradycardia, okay? So those are the two times when you might see an epi drip running. Any questions about epi, guys? All right, so how do I mix it? What do I do with it? Traditionally, we can make a concentration of 4 mics per ml by putting that in a 250 cc bag. So you just take your, this comes in every drug box, just like that, right? What's the concentration of this? Okay, so it's 1 to 10,000. We wouldn't want to do what? Please don't. So I want to take a 1 to 10,000 dose of epi. All right, this whole thing is how many milligrams? 1 milligram. So if I put 1 milligram, okay, how many micrograms are in 1 milligram? How many? 1,000. So if I take this full milligram and put it into a 250 cc bag, does everybody see how I got 4 mics per ml? What if I put it in a full liter? I'm not going to, but what if I did that? What would be my, right? So I'm just saying you use what you got, but usually we mix it this way. So what type of dripper set would you guys use for a vasoactive drip? Huh? A 60 drop set, or also known as micro. All right. So if we wanted to give this patient, based upon these calculations, if I told you, let's start this, not basal, if the doctor said start them out at 2 mics, if the doctor said start them out at 2 mics per minute, how would you dose that out? I might have. So if 60 drops is 1 ml, 1 drop per second, I think that was the lowest I. How about let's do that 8 mics. Actually, it'd be a half drop, which you can't do. So because of the way the concentration. But either way, so for 8 mics per minute, if 1 drop per second fell, that would give you 60 drops per minute, right? Okay. That and 60 drops equals how much? In this concentration up here, it would be 4 mics. So if I wanted 8, I would have to do 2 drops per second. Okay. If I wanted to double that, I'd have to do 4 drops per second. That'd be getting pretty fast. I don't know how you count that. So you can see why changing the concentration actually might help, depending on what you're looking for. Dopamine. Somebody said earlier, dopamine activates different receptors based upon the concentration. So if I want an alpha effect from my dopamine, what concentration do I need to be running it at? 10 to 20 what? Yeah, so 10 to 20 mics per kilo per minute if I want to get that alpha effect. Renal dosing is something that is kind of lost favor. It's kind of controversial. Basically, they found that it really doesn't hurt the kidneys at all, but renal dosing was traditionally started out at about 2. But they said basically all it does is just really increase the perfusion to the kidneys. Doesn't really have to do with actually being kidney sparing. So regardless, every patient is different. Okay, even though we have these rules as to where we get certain effects from, every patient is going to be just a little bit different. All right. So the important thing is I would start titrating out about 4 or 5, and then bump them up till you get the effect that you need. Okay. Dopamine, like I said down here, the AHA usually starts at about 5 to 10 mics per kilo per minute for the ROS patient. 2 to 10 mics per kilo per minute if they're in bradycardia. Another thing, as far as AHA goes, they recognize that both dopamine and epinephrine provide the same beneficial effect as external pacing, as just by using one of these 2 drugs at this concentration over here. I'm losing my voice. How do we get these? Anybody know any quick, easy rules as far as how to measure out and how to dose out your dopamine? Has anybody heard anything? Did you give them any tricks to the trade, Paul? Come on now. Anybody heard of magic number, dopamine clock, any of these things? Ring a bell?
It's okay if he asks you.
You just told him put it out of your mind for now, right?
They have to show their work. That's the key.
You do have to show your work. And I'll tell you what I do, what I use these tricks for. They usually do work or get me close. But one of the reasons why, and I agree with Paul on this, is because if you use this magic number, it's not going to be exact. It's not going to be as exact. Now I can show you a way to get it more exact, but I'm not going to do that right now. But ultimately, you can find out how to dose it. 3 a.m. in the morning, you're tired, and and you don't have your phone on you. You can find out how much the patient weighs. And when you do, all you have to do is just drop the last number of his pound, how many pounds he weighs, And from there, if you have a 1600 mic per ml concentration, you can just drop the last number, and that's how many drops per minute that you want to administer. All right. What time we got? I'm just gonna blow through some of these here. I won't talk about the dopamine clock because you guys already learned it. What's that? Please no.
Please nod yes.
Why do you think that we use all these? Where do you think did some guy just randomly come up with these different numbers for these drip sets? Why do you think he came up with them? Just because they worked? I mean, because fluid flowed through them at a rate he liked? I mean, where did he get these numbers? Why didn't he make it 37? I got a drip rate of 37. My macro drip gives me 1 ml with 37 drops. Why did he pick that? Why wouldn't he pick that? I mean, easier math, yeah. Questions, right? But honestly, it works very well with the whole idea of the clock method. So if you guys want to learn more about that, I've actually been able to apply that to almost any medication that I administer with a 60 drop set. You can do it. So norepi, this is one of the first line drugs that you're going to see in somebody who comes in with sepsis. It has some beta-1 stimulation. However, it is very, very much loves what receptor site? The alpha receptor sites. Okay, so what are we going to see with norepi? A lot of vasoconstriction. Phenylephrine. I actually do use this on my unit quite frequently. In fact, last night we had a pediatric patient who kept having bloody nose, couldn't stop the bleeding. So we use this neosynephrine or phenylephrine. What is that for? Why do you think that works? Isn't this something we use for nosebleeds? What is that? What does phenylephrine do? Huh? Why would I use it to stop bleeding, though, is what what I'm asking. It causes significant vasoconstriction. So if you're having a massive bloody nose, like my patients up on my floor have like 0 platelets. Like I'm talking like maybe 10 of them roaming around in there. So I need to find some way to stop that bleeding. And one of the ways we do it is using these phenylephrine nose drops. And what they do is they act on those alpha receptor sites and just clamp down really hard on that vessel that's bleeding. Dobutamine, I told you, has that strong beta-1 adrenergic effect. It's gonna, if it's a beta-1 agonist, it's gonna increase what? Huh? Say it louder, guys. Be proud. Contractility. What classification of drug would that be? A what? What is it, Paul? I see. I hear like 4 different things up here. What is it? Inotropic. All right. So I'm not going to go over some of these. Nitroglycerin. I'll bring up a couple things about nitro. It does cause what type of dilation? Huh? I can't hear you guys. You guys are too quiet. Wake up, man.
Venous dilation.
Venous, okay. Well, does it have any arterially dilation? Yeah, it does a little bit. Yeah, it does. Coronary, especially in the coronary arteries. Where is this going to affect our stroke volume by giving our patient this? Yeah, it's gonna cause a preload problem, right? So I will just point out one thing here with this type of a drip. It does come in a glass bottle. So if you guys have ever seen this little top right here, you're gonna need to make sure that anytime you have a rigid or glass bottle that you need to open this vent cap. Okay, otherwise what's gonna happen when you stick it in there? Anybody done that before? If you go to spike a glass bottle and you haven't vented it, it's just gonna suck that chamber flat. because of the pressure. So because the bag normally will just change the space, but you got to be able to vent it, and then it's going to create an airlock, and it won't flow. So let's see. I'm not going to go over all these guys because I want to get to some other fun stuff. All right, so we're gonna stop there, and because I've got a couple people here who I want to get to them, and I am rambling. So let's see here.